All right. Well, good morning, everybody. I hope you had a good weekend. My name is Lindsey Jung. I'm one of the clinical pharmacists that works primarily in our lung and GU clinics, but I also do cover melanoma and sarcoma. So today we'll kind of be covering part two of solid tumors. So looking at our targeted therapies and monoclonal antibodies. I can get, sorry. All right, so for learning objectives, we will kind of talk about the different medications we use in the treatment of GU cancers, looking at the mechanism of action, drug interactions, and side effect profiles. We'll also discuss some treatment barriers, including financial toxicity and supportive care that we use for these medications. And then for the last part of our lecture today, we'll look at the use of targeted therapy and treatment of non-small cell lung cancer. Again, kind of looking at how these drugs work, some drug interactions to look out for, and the side effect profiles. So pretty soon it's going to be November, so we're going to see a lot of nasty beards and mustaches come out. But of course, this is all kind of to bring awareness for prostate cancer. When I was making these slides this year, I did learn that the Beard and Mustache Championship is going to be in Wyoming this year, if anyone has time off. And they also have aligned it with the Whiskey and Bacon Festival. So I did include the winner of last year's competition, so you guys can have some inspiration. But of course, it's always a good cause to get involved with. So talking about prostate cancer, we know that this is a disease that's highly dependent on testosterone to kind of supply that cancer growth. We'll cover kind of the GnRH agonists versus antagonists as their first kind of class of medications. These are also called LHRH agonists and antagonists. Big difference between the mechanism of action here. Of course, your agonists are going to be kind of stimulating those receptors, which initially leads to an increase in LH and testosterone production. However, over long-term administration, this eventually leads to suppression of LH, resulting in suppression of testosterone. On the other hand, the GnRH antagonists have an immediate onset of action, so this prevents gonadotropin release through receptor blockade, leading to rapid suppression of LH and testosterone. So kind of looking at these drugs, I have a nice comparison table here. Our agonists are on the left-hand side, so both leuprolide and goserelin. On the right hand, we have our newer agents, which are those antagonists. So dagerelix and relugolix is the most recent one that's come onto the market. You can see some differences in our dosing. For our agonists, there are kind of some longer acting formulations, which can make it nice for patient, adherence, and they have less visits that they have to be in for. So you can use up to a 6-month formulation, specifically with something like Lupron or Eligard. On the other hand, on the antagonist side, we do have one oral formulation available, and that's the relugolix. Patients will have to do a one-time loading dose of 3 tablets, followed by 1 tablet daily. When we think about these medications in general, it's suppressing testosterone, so we're going to have side effects like hot flashes, fatigue, arthralgias and myalgias, erectile dysfunction, and gynecomastia. Long term, we're kind of focused on things like osteoporosis, metabolic syndrome, so potentially things like an increased cardiovascular event risk, changes in lipids and diabetes, but also potentially things like obesity and decreased muscle mass. Differences kind of between the different adverse effect profile. So with the agonist, because we have that initial kind of overstimulation and increase in testosterone with the start of the medication, we have the phenomenon of tumor flare. On the other hand, when you use that antagonist, because it has that kind of faster onset and immediate suppression, there is no tumor flare. So if we are using something like leuprolide in patients who have overt metastases, we should always be using something like an anti-androgen to block those testosterone receptors to kind of minimize that risk of tumor flare. So we do this for at least in combination for 7 days to kind of help prevent that tumor flare. The other big question between these two classes of medications is whether or not there's a huge difference in cardiac risk between the two. We'll kind of go through some of the literature that kind of discusses that on the next slide. But it's thought that the agonists potentially do have a higher cardiovascular risk. So it's sometimes a consideration for patients who have a lot of cardiac history. Some other considerations for injection site pain and reactions. The Zoladex is a sub-Q implant, so it does tend to cause a lot more pain. Typically, order sets will have lidocaine that's used to kind of numb that area before it's injected. We've also had some chronic shortages of Lupron, which can cause some issues. So potentially having to change patients between the Lupron formulation and Eligard when that happens. On the other side, when we're talking about those antagonist medications, these are newer, they tend to be more expensive, and so we can get a lot of insurance barriers here. With any oral medication, we're going to have to consider drug interactions. So if you're thinking about Relugolix for a patient, you may have to consider that it does inhibit PGP. But again, this is a medication that would work quickly if you are looking for a quicker onset. So looking at the cardiovascular risk factors or kind of that data behind all of this. So in general, we know that the use of androgen deprivation therapy has been associated with the higher cardiovascular morbidity and mortality in studies. So this typically happens, especially in patients who have cardiovascular risk factors and some sort of pre-existing ASCVD. They're still trying to figure out and tease out within these different trials whether one class causes more cardiovascular risk versus another. So I've included kind of 3 of the primary ones. The first one, the Albertson et al. Study from Urology in 2014, was actually a post hoc analysis of 6 phase 3 trials. So looking at Degarelix versus Lupron. What they found is in patients who didn't have a cardiac history, there wasn't really a difference between the 2 classes of medications. However, when they saw somebody who did have that history, the incidence of death or cardiac event was lower in patients who had an LHRH antagonist, and that was statistically significant. Some strengths and limitations, this didn't only include phase 3 data. There was a lot, a variation of times or median durations of these trials. So you did have a very short follow-up of 3 months included as well. The other thing to note is, of course, this is a post hoc analysis. So technically, we should only be looking at this as a hypothesis generating kind of study or result that we're looking at. The next series of data that came out, so there was a phase 2 in 2019, again, kind of looking at Degarelix versus Lupron. When they looked at their primary outcome, they were actually looking at changes in endothelial function at 12 months. And they found no difference between that. But looking at the secondary outcome, a new cardiovascular event was higher in patients receiving that agonist treatment versus the antagonist. This was a pretty small trial, so only 80 patients were included, obviously a phase 2, so not our strongest data that we're looking at. But the nice thing was they did include only patients who had pre-existing cardiovascular disease. The last trial that I have included is the Pronounce, which was a phase 3. So this was kind of the one that everyone seemed to be waiting for to see what kind of outcomes they would have. It was a prospective evaluation of cardiac events. So different from these other trials that they were essentially just kind of looking to see whether or not that adverse effect was higher in the outcome. So not necessarily powered for it. But what they found in this Pronounce trial was that there was no significant difference in outcomes at 1 year. Looking at the number of events, so they only had 15 patients with some sort of event in Degarelix arm versus 11 in Leuprolide. So unfortunately, that was one of the limitations of this trial, was that it was terminated early due to lower accumulation and smaller number of cardiac events. Of course, it is something where it was a larger phase 3. It was international, included patients with cardiovascular history. But I think to kind of summarize, I think the jury is still kind of out on this. If you do have a patient who does have a lot of cardiovascular risk factors, it is potentially worthwhile to consider the use of an antagonist. There's a lot of theories about why there may be a difference. Looking mechanistically at the 2 different classes of medications, it's thought that the antagonists would not activate T lymphocytes, which could potentially increase atherosclerotic plaque rupture. And there's also kind of a thought that potentially FSH could play a role in endothelial function, lipid metabolism, and fat accumulation, which is why the agonists cause more events. So I mentioned that we do have to use an anti-androgen if we are starting something like Lupron. Pretty much no matter what, you're going to see bicalutamide used. This has now kind of taken over, I think, just because of tolerance and the fact that it's 1 tablet 1 time a day, and overall pretty well tolerated. The other ones to know of, there's flutamide and nilutamide, now have kind of been more of like a historical drug as bicalutamide has taken over. In terms of class effects, these all potentially can cause hepatitis or transient elevations in AST and ALT. They typically all have similar potency. One of the phenomenons you might see is that eventually all of these agents develop agonist versus antagonist activity due to that constant stimulation of the androgen receptor, which may cause the PSA to rise. So sometimes when you discontinue something like bicalutamide, you might actually see a decline in the PSA. We also have a second generation of anti-androgens that has kind of taken over the market a little bit. You've probably seen some commercials for Nubeqa recently because it just got a new indication. Differences between these two, with this class of the second generation, we have a lot more pill burden. So you can see that with anything, they're taking at least 4 tablets one time a day, potentially splitting that into twice a day dosing with darolutamide. With any kind of oral chemotherapy or oral drug that we're talking about, always important to consider if it's specifically with or without food. Darolutamide is the only one that carries a designation that it has to be taken with food. A couple things that stand out to me when I'm thinking about these medications is the fact that both the apalutamide and enzalutamide have a lot of drug interactions. So especially when you're starting somebody on these medications, it's good to kind of take a look through that medication list or find your friendly pharmacist in clinic so we can help evaluate whether or not we're going to run into some nasty drug interactions here. I've listed some of the common ones. Of course, in patients who have a lot of cardiac history, they're probably going to be on a statin. They may have some sort of anticoagulation on board. So we commonly run into issues with things like apixaban. Clopidogrel or other kinds of antiplatelet agents can also be common for drug interactions, and calcium channel blockers. For differences in side effects, both enzalutamide and apalutamide specifically excluded patients from their trials who had a history of seizures. These do carry a little bit more of a seizure risk. It's still pretty low, it's about 4% or less, but good to know when you're talking to patients about these medications. They also tend to cause a lot more fatigue. And essentially that fatigue and seizure risk kind of indicates that both of those medications have a lot better blood-brain barrier penetration, whereas darolutamide, it's okay to use in patients who have a seizure history. Those patients were included in those trials, and it also causes a little bit less fatigue than the other 2 medications on this page. We do have to also consider for darolutamide that it would need a renal dose adjustment. The other medication to talk about today for prostate cancer is abiraterone acetate, which is always a mouthful to say to your patients. There are 2 different formulations. There's Zytiga, which is our preference and formulary agent at UW, and there's also Yansa, which is a micronized formulation. So obviously important to know between the 2 because they're not technically interchangeable. For both of these agents, again, is some sort of a pill burden, so at least 4 tablets once a day. There are some differences in dosings. There's always some sort of steroid on board with either one of these formulations. For the Zytiga formulation, prednisone's dosed at once a day, 5 milligram tablet. And if it's a castrate-resistant prostate cancer, we're dosing that prednisone at twice a day. Big difference between these 2. For Zytiga, it must be taken on an empty stomach. Any kind of food, especially fat, can significantly increase the absorption of the medication and can lead to more side effects. On the other hand, that micronized formulation, one of the reasons why they kind of did that is because it can be taken with or without food. These both work as a CYP17A inhibitor, so different from the other medications we've talked about. So these block the synthesis of androgens, specifically DHEA, and also can potentially, with that, cause reductions in cortisol and lead to a compensatory increase in ACTH, which I'll kind of point out in the next slide as well. For side effects, edema, hypertension tend to happen a little bit more frequently with this versus the other medications we've talked about. And a lot of these side effects can be linked to that mineral corticoid excess that we can see if the prednisone's not dosed appropriately. We also have to watch LFTs very closely when they start this medication. So looking at LFTs every 2 weeks for the first 3 months. Things that I do want to point out for the Zytiga formulation, as I said, food significantly affects the absorption. There is some limited data to support a dose of 250 milligrams once daily with a low-fat breakfast. It can be done for financial toxicity reasons if the patient can't afford the higher dose. However, it's pretty erratic, the amount of absorption that patients have from that lower dose, and we don't commonly use that here at UW. So in summary of all of these agents, looking at the different mechanisms, of course, our GnRH antagonists will work in the pituitary. You can see the abiraterone there kind of in the middle, kind of working more on the synthesis of that DHEA. And you can see how it has that different effect where it also can cause some effects on ACTH. And then downstream, looking at the cell, the actual prostate cancer cell, the androgen receptor antagonists work directly within there, kind of blocking that androgen receptor. Thinking about our place in therapy for all of these different drugs we've just talked about, I tried to summarize nicely the different indications that we have. I feel like all of these drugs are sort of battling for their place and where they're used in treatment of prostate cancer. I'll point out darolutamide and apalutamide have a non-metastatic indication, whereas abiraterone and enzalutamide do not. The other thing to kind of note when we're looking at metastatic castrate-resistant prostate cancer, daro and apalutamide do not have that indication yet. One of the big things that's starting to come out is this treatment intensification with docetaxel. So in these patients with de novo metastatic disease who have a little bit more high volume or higher risk disease, using concurrent docetaxel with some sort of androgen therapy. It's important to note at this point from the PEACE-1 trial and Arisons that only abiraterone and darolutamide have the data to support concurrent use with chemotherapy, androgen deprivation therapy, and kind of our standard of care. Some other considerations that I've kind of alluded to, patients who have a really significant cardiac history are going to have a lot of drug interactions. So again, please find your pharmacist. We can help walk you guys through that. Listed kind of some of the common ones that we run into. So again, statins, calcium channel blockers, your antiplatelets, and the DOACs especially. Even warfarin, which we hope nobody's on warfarin, but it always does come up every now and then. So just kind of a little summary of how we manage these interactions. So it's a lot of communication between primary care or whoever's managing these blood pressure medications and our oncology team. But considerations that we can switch to, pantoprazole, avoids a lot of the interactions that omeprazole can kind of fall prey to. Talking about antiplatelet medications, prasugrel tends to be a little bit cleaner. And then for DOACs, we sometimes have to consider use of dabigatran or Pradaxa, adoxaban, or even potentially warfarin, since we can kind of manage those levels. A big thing that we also have to manage with these patients is that, unfortunately, it's an older population. A lot of them are on Medicare. These drugs are extremely expensive, so we'll do our prior authorizations and get a copay of $10,000 for some of these patients. And then, of course, there's the pitfall that they can't use a standard copay discount card because they have that government insurance. So unfortunately, there can be a lot of delays as we kind of try to assess whether or not we can make these medications affordable. It's almost like a little game we have to play, looking for free drug programs. But unfortunately, that is dependent on their income. So if there's somebody who has saved for retirement appropriately, then they don't qualify for a lot of those free drug programs. There's also a cost plus drugs. It's the Mark Cuban website that's recently kind of popped up. It does kind of require these patients to be able to use the internet, which I know if it was my dad, he probably would fail at getting signed up for this program. But it is an option that we potentially can offer specifically for something like abiraterone. It can make that cost from $3,000 to $170 a month. There's also GoodRx. I've been sending patients to Costco for that to get their cost-controlled hot dog and now their cost-controlled abiraterone. And then we occasionally will have some grants that we can find, but those aren't always readily available. So we'll move more into urothelial carcinoma now, kind of talking about our bladder cancer patients. All of these drugs will be more specifically within the metastatic setting. The first one we're going to cover is erdafitinib or Balversa. This is typically kind of second line after chemotherapy progression or after immunotherapy. It's dosed at 8 milligrams once a day. And it's a little bit different as we do have to kind of assess the serum phosphate levels within 14 to 21 days after initiation. And you can see kind of the specifics there. So potentially increasing that dose if phosphate is less than 5.5. The reason why we have to do that, this is a pan-fibroblast growth factor receptor, FGFR kinase inhibitor. So what they found with this kind of class of medications is that it increases phosphorus reabsorption in the body, which leads to hyperphosphatemia. We typically can try to control this with things like diet restrictions, which can be hard in Wisconsin. The standard recommendations are to reduce dairy and meat intake. We also can consider things like phosphate binders like sevelamer to add on to help reduce that phosphate as well. However, we need to kind of avoid those during that first initial period to kind of see where that phosphate falls and then manage after. So the median onset is 20 days of that change in phosphorus, and this is fairly common. It happens in about 75% of all patients. Beyond that, it's fairly well tolerated. There's some potential for skin rashes, changes, potentially dry mouth, taste changes, and then changes in nails as well. More rarely, it can cause things like conjunctivitis, blurred vision, or even a retinal detachment. The other thing to note with this medication is that patients do have to have a specific mutation, so they have to have this FGFR genetic alteration to use this medication. On this slide, I've kind of outlined how we would manage that hyperphosphatemia. So you can see that a certain level of elevation is acceptable, that, if we came back at day 14 to 21 with that little bit of elevation, we would continue at the current dose, but then kind of monitor monthly to make sure that we don't have continuous elevations in that phosphorus level. As you kind of see that phosphorus continue to elevate, so anything above 7, we're now talking about holding the medication and potentially doing, if it's within 7 to 9, you would continue at the same dose. However, if it persists for more than a week, you would consider a dose reduction. Anything above 9, we're talking about holding plus potentially a dose reduction at that point. The next medication is enfortumab vedotin, or Padcev. This is one of those antibody drug conjugates that you're going to see a lot of these probably come onto the market. It seems to be kind of one of the hot new things that the drug companies are coming out with. This is dosed weekly with an off week every 28 days. And the mechanism for this one is it is a Nectin-4 monoclonal antibody target coupled with a microtubule agent. So the same one that you've seen in other medications is this MMAE microtubule agent. Things to know about the side effects for this one. It doesn't cause a lot of nausea, and it also has a lower risk for febrile neutropenia. The big things to look for, rash happens in up to 55% of patients, and most commonly will occur during cycle 1. And these can actually get pretty severe. So grade 3 can happen in up to 13% of patients, even getting to like a category of dermatitis bullous or a hand-foot skin reaction toxicity. The other big thing that we definitely counsel patients on when they're starting this medication is ocular toxicity. They do need to use kind of eye drops as needed for dry eyes. So we kind of just prescribe or give like a little instruction on how to use those. If it does get to be pretty severe, we may have to consider holding that treatment or potentially even using things like steroid eye drops to help treat it. A couple other side effects, hyperglycemia and peripheral neuropathy. Again, it is kind of a microtubule agent. So that neuropathy is something that's definitely going to appear. If a patient is having any hyperglycemia, we do have to hold if that's above 250. And then if we can kind of get that under control with agents like metformin or kind of management, we can keep it at the same dose. So looking at how we actually manage this rash. So because it's that Nectin-4 inhibitor, we kind of need to talk to patients about what they can do at home. First, of course, it's always good to have sunscreen, protect their skin from UV light. We'll look at the different areas that this rash can appear, but there is some data to kind of support barrier agents like zinc-containing moisturizers or Desitin and intertriginous areas like the armpits or groin. For the rest of their skin, they can moisturize that with any of those thick creams that you've heard about for hand-foot syndrome or hand-foot skin reaction. They should also try to minimize exposure to hot water. And with each cycle of chemotherapy, they should have that skin assessment to make sure that they don't have any skin rash popping up anywhere. In terms of the management, so if we do have just kind of a lower grade, grade 1 or 2, we're most often going to use something like a topical corticosteroid, so either hydrocortisone or maybe something like triamcinolone or clobetasol. We can also consider something like a topical antibiotic like silver sulfadiazine. And then if they have that itching or kind of discomfort, antihistamines. If it's a grade 2 and it looks a little bit nastier, we can also consider something like an oral anti-infective or some sort of antibiotic to help manage. For any grade 3, we should be holding until that gets better and resolves to less than grade 1, and then doing a dose reduction. The other things that we can consider at that point, adding on a steroid, so something like prednisone, or getting our derm colleagues involved to help manage this as well. As I said, this rash can get pretty severe, so it even can cause things like SJS or TEN. So obviously, if that happens, we probably never want to retrial the drug again. But certainly any grade 4, we're probably talking about inpatient management of that toxicity. So looking at the pictures of the different things that can happen, this Nectin-4, it's well expressed in our normal tissue, so including our epidermis and then sweat glands, hair follicles. So you can see things like alopecia, that rash that can appear anywhere, kind of that baboon-like presentation where it kind of has that red skin that appears in the intertriginous zones, or even just a maculopapular rash that can happen. So this can be, pretty uncomfortable and pretty painful. You can also kind of see it. Sometimes it's just this like scaly or almost bruised-like rash that can appear. But, the thought is that this Nectin-4 really causes some disturbance in those cells and causes that irritation that leads to these rashes. Sacituzumab is another drug that we use for metastatic bladder cancer. This is indicated for subsequent line therapy. So at this point, patients typically will have prior chemotherapy, immunotherapy, or enfortumab beforehand. It's another antibody drug conjugate. This is also used in breast cancer. Kind of the initial indication was for breast cancer for this drug. So this is a TROP2 monoclonal antibody that's coupled with a topoisomerase 1 inhibitor, or SN38, which you may recognize that's also the active metabolite of irinotecan. We do have a little bit of a risk for infusion reaction with this medication, so patients do have to get some pre-meds beforehand. Other kind of big side effects to look for, it is a more moderate emetic risk, also has a much greater chance of causing significant neutropenia, and an intermediate risk for febrile neutropenia. So thinking about the NCCN guidelines, if you have a patient who kind of has those intermediate risk factors, if they're older, if they have significant, renal impairment, kidney dysfunction, issues with their bone marrow, we may want to consider upfront use of G-CSF with this agent. Diarrhea is very similar to irinotecan. It's the same metabolite, so we can both see, an early phase that's more cholinergic, and then also that late phase that can happen up to weeks later. Just a couple other things I wanted to point out. Up to 39% of patients in the TROPHY trial, which was a trial for bladder cancer, had some sort of dose reduction for neutropenia, fatigue, or diarrhea. So it's not a very well tolerated agent at that full dose, especially since these patients are usually pretty heavily pretreated. It's a moderate emetic risk, but we quickly escalate to a high risk. So consider adding IV amend if these patients are having issues with nausea. And we also counsel similar to what we do for irinotecan patients. So use of Imodium at home and then escalating that as needed. So I did want to quickly review a patient case that we had that kind of walks you through, the progression of some of these patients. So this was a 76-year-old who had recurrent but now metastatic urothelial carcinoma. He had 1 cycle of carbo and gem, but this was discontinued for poor tolerance. Changed to Pembro, unfortunately had disease progression. So then we started him on enfortumab vedotin. After his first dose, he was unfortunately admitted for weakness and diagnosed with aspiration pneumonia. During that admission, we also found that his ANC was less than 1,000, so we ended up doing that dose reduction. And then at cycle 2, day 8, he called in for a new rash. So I have some lovely pictures here, but you can kind of see, again, it's that like weird bruised, almost scaly rash that appeared on his arms and also on his feet. He also had some significant worsening neuropathy after the more recent infusion, and then reported this painful burning skin rash with some blisters on his hands that eventually moved to his feet. So at that point, he was prescribed hydrocortisone for the skin rash and then managed with pain medications at home like oxycodone and dexamethasone that he already had on hand. At 3 days, he felt like that redness improved, but the redness had worsened, but the pain was better. By the time he got to his next cycle, we were ready to retreat, ended up dose reducing, and he stayed on that dose for about a year before he had progression. So at that point, we changed to sacituzumab at the standard dose, the starting dose of 10 milligrams per kilogram. Unfortunately, after day 8, he had weakness, came to the ED, and eventually was admitted for febrile neutropenia. He was having more than 10 loose stools per day, and we saw his ANC was about 360 on day 15 of that cycle. So at that point, doing a dose reduction, considering the addition of GCSF, so kind of doing that spot dosing since this is a weekly administration of chemo. He unfortunately had worsening nausea and vomiting. So then we added olanzapine and IV fosaprepitant to his treatment. Unfortunately, went back into the hospital, had some febrile neutropenia, and was treated for E. coli bacteremia. For his next cycle, a lot of discussions about whether to continue or not, but he was dose reduced to 5 milligrams per kilogram, continued to have 10 loose stools per day, and we had already previously maximized his dose of loperamide and Lomotil at home. So we looked into the addition of tincture of opium, which unfortunately required a prior authorization through insurance, but still cost about $200. So just kind of a nice summary of how tough these drugs can be to tolerate in these bladder cancer patients. Unfortunately, this guy just seemed to have everything. So we'll move now into renal cell carcinoma. We know that this is a disease that's not very chemoresponsive, and so there's a heavy utilization of immunotherapy and also these VEGFR TKIs. So for our common adverse events, we're going to focus in on those VEGFR side effects. So, all of these agents work by kind of cutting off angiogenesis. So we're going to see changes like hypertension, proteinuria or nephrotic syndrome, wound healing complications, hand-foot skin reaction. There's a risk for thrombosis with any of these drugs. We also run into issues with cardiotoxicity like LV dysfunction or QT prolongation, hemorrhage. There are certainly some voice changes that can happen where you just have like more of a hoarse voice that occurs over time, mucositis, diarrhea, and changes in thyroid. So whenever you think about these VEGF TKIs, just think lots of side effects. It's kind of my good summary there. So initially, sunitinib and pazopanib were kind of used earlier in treatment of metastatic renal cell carcinoma, but these now have been more shuttled to other recommended regimens for clear cell. For non-clear cell, however, you still might see sunitinib kind of listed as that first-line preferred regimen. However, that's kind of listed alongside clinical trial. So we know that those patients with clear cell or non-clear cell don't have as many options, unfortunately. So these drugs, just to kind of summarize quickly here, some differences between the two. Pazopanib is you have to take it on an empty stomach. It's very sensitive to any acid suppression. So we also see some drug interactions there. Both are CYP3A4 substrates, so we have lots of drug interactions to consider. Sunitinib does have that once daily dosing for 4 weeks on with 2 weeks off. At the bottom, I've kind of listed that there's also this continuous dosing scheme of 37.5 milligrams once daily that's been evaluated, and that has more data to support in treatment of GIST or PNET, but not as much with renal cells. We typically don't use that continuous dosing scheme. For side effects, we'll kind of talk about these in a little bit more detail in the next slide, but overall, not well tolerated. There's a lot of rash, fatigue, and mucositis, a lot of diarrhea with pazopanib, abdominal pain that we can't really treat very well, and also some LFT elevations that can happen. One thing that we have considered with pazopanib, and we've done for sarcoma patients too, is titrating that dose. So it does come in those 200 milligram tablets. You can consider starting at 200 and then increasing by 200 every week to get to the maximum dose. Sometimes that's helpful in improving that tolerance, but it's also something that we could use a little bit more data for as well. When I was making these slides, I honestly got a little bit triggered looking at the villains. This is what I think of though when I'm thinking about sunitinib or pazopanib. These honestly, like I said, are both so not well tolerated. There were two trials that looked at which one was worse than the other. So kind of looking at, whether Joffrey was worse than Ramsay Bolton. But the COMPARES trial was a phase 3. This, took treatment naive metastatic clear cell renal cell patients, and they were randomized to receive either pazopanib or sunitinib. What they found was similar progression-free survival and overall survival, regardless of which drug the patient was on. Importantly, they found more fatigue, hand-foot, skin reaction, thrombocytopenia with sunitinib, but more LFT elevations with pazopanib. They also looked at quality of life scores, and all of those favored pazopanib as well. In the Pisces trial, this was a phase 2. It actually had a really cool setup. Again, we're looking at treatment-naive metastatic clear cell patients. The patients were randomized to either pazopanib or sunitinib for 10 weeks, followed by a 2-week washout, and then crossover to the other drug for 10 weeks. What they found, majority of patients, about 70%, preferred pazopanib over sunitinib, and that was statistically significant. Again, the same kind of trends. There's less fatigue, skin changes, and mucositis with pazopanib, but less diarrhea with sunitinib. They also surveyed physicians in this trial, and the physicians tended to prefer pazopanib over sunitinib as well. So moving on to like our newer VEGFR TKIs that we use. So these are either more potent or have more selective, kind of less off-target effects than those earlier generation like sunitinib or pazopanib. Cabozantinib or Cabometyx, we can see that either just once daily as a single agent or also in combination with nivolumab. And it's important to note the dose does change depending on which you're using. Axitinib, on the other hand, is a twice daily dose, so 5 milligrams twice daily, but you can increase to a max of 10 milligrams twice daily if tolerated. Again, the difference is in administration. So cabozantinib must be on an empty stomach, important 2 hours before, 2 hours after food, whereas axitinib is less picky. With the mechanism of action between these two, the thing to point out here is that axitinib is that more selective second generation agent, so only blocking VEGFR instead of the other off-target effects like cabozantinib has, meaning that we generally have better tolerance with the axitinib, so less of those extra side effects from the extra targets. Both of these will have CYP3A4 interactions, so important to assess for that. And differences in the side effect profiles here. As I said, axitinib, much better tolerated, potentially things like fatigue, diarrhea, hypertension, and arthralgias I've seen in our patients. But with cabozantinib, it just tends to be a lot tougher. It causes more nausea. There's much more fatigue. You have a lot more of that hand, foot, skin reaction, and certainly some more of that hypertension as well. Other things to note, cabozantinib also inhibits MET, which is a common mechanism of resistance to VEGF TKIs. So potentially thoughts maybe have a longer effect with this medication since you're blocking that common resistance pathway. For axitinib, it's interesting how this medication is dosed since you kind of start at that midpoint range. So you can either kind of increase to 7 milligrams, then 10 milligrams twice a day if they're tolerating well, or potentially decrease to 3 milligrams or 2 milligrams twice a day. And these are our newest ones that have kind of come out or been indicated for renal cell. The newest agent, tivozanib or Fativda, just came out in March of 2021, so certainly our newest one. Lenvatinib, similar to cabozantinib, you'll see it either kind of in combination with different agents, and that dose does vary. So if it's with everolimus, that dose is lower. If we're using it in combination with pembrolizumab, the dose is going to start at a higher dose. Tivozanib is one kind of like sunitinib where we do have to have a cycle of treatment. So important to make sure your patients know that they do have to have an off week with their cycle. Tivozanib is very similar to axitinib in that it's more selective in blocking just VEGFR, whereas you can see lenvatinib is a little bit dirtier. It hits a lot of other receptors kind of off target, and so we have a lot more side effects and decreased tolerance with lenvatinib. For tolerance, for side effects, your standard VEGF side effects, I will point out that 20 milligram dose is really hard to tolerate for our patients. There's a lot of fatigue and arthralgias and myalgias when we're doing that with lenvatinib, a lot of mucositis as well. The cool thing about lenvatinib is that it does come in these therapy packs, so kind of similar to venetoclax, where it's nicely laid out and patients will punch the medication out of their daily slots. For tivozanib, it, as I said, does seem to be a little bit better tolerated. We certainly can see things like fatigue, changes in blood pressure, diarrhea, and rash. But this is now technically only indicated in the relapsed refractory setting after 2 prior treatments. So it's the agent that we're kind of reaching for more as like a last line. And I did have to include the new kids on the block for the newest one for Fativda. The other thing with renal cell, so kind of the hot new thing is that they are doing immunotherapy plus VEGF combinations. So they definitely have a little bit of a synergistic action in that, you know, we're kind of affecting T cell trafficking and infiltration with both of these agents, and then kind of helping to present those antigens and priming those T cells with the combination as well. I've bolded a few here: cabozantinib plus nivo, axitinib and pembro, lenvatinib and pembro. Those are all preferred first-line therapies for clear cell, favorable risk patients. Axitinib and avelumab just didn't have as much of that data to support it yet. And you know, thinking about which agent we're going to pick, a lot of physician preference will come into play here. As I said, lenvatinib can be really hard to tolerate, but it can be something that, you know, they feel like it could have a little bit more effect versus something like lenvatinib, or sorry, axitinib. Axitinib does have a shorter half-life, so if you're worried about toxicities with these patients, it's easier to kind of hold and it'll have a quicker off to help manage those toxicities. But I would say more commonly we do tend to see cabozantinib plus nivo or axitinib plus pembro as our options that we use here at UW. And cabozantinib, the preference there comes from the fact that it is supported by monotherapy on its own. And so it does have some data to kind of show that activity without the use of immunotherapy as well. This is a little bit of a busy slide, but I thought it'd be a nice reference. This summarizes all of those potential trials, again, kind of trying to show some differences. We have very similar, you know, overall survival, progression-free survival with a lot of these TKI plus immunotherapy combinations. And again, you know, it comes down to physician preference, to the patient picture, what they're going to be able to tolerate in terms of which one that we're starting for them. Side effects, certainly something significant with these. Hypertension can happen within 29 days of starting one of these VEGF TKIs, but also can occur quickly, like within 2 weeks. So it's important to kind of mention that to your patients, that they should be monitoring at home. If they have a larger BMI, if they're older, or if they have pre-existing hypertension, we know that they're at greater risk for having that increase in blood pressure. So when I'm talking to patients, I usually do recommend monitoring their blood pressure once a day, and those who already have blood pressure or any other significant risk factors. In terms of management, we do need to start some sort of antihypertensive if they aren't on something already, if that blood pressure escalates to the hypertensive range. We should also be holding if they get anywhere above 160 over 100. For our management, our first line recommendation agent is a calcium channel blocker. It seems to be much more effective. So amlodipine 5 milligrams once a day. For second line, we should be considering something like an ACE inhibitor or an ARB, so potentially something like lisinopril. That especially can be helpful if they do have some sort of proteinuria as well. What they found in the management of this particular side effect is that diuretics tend to be much less effective. And I think you guys already kind of covered this with Liz as well, but just kind of some quick notes here. Is the hand-foot skin reaction. Important to know that this is distinct from the hand-foot syndrome that you can see with chemo. It typically presents as these hyperkeratotic lesions on the hands and feet. It can also have symptoms like burning, paresthesia, or tingling. And you can see those like callus-like blisters that form. Patients can also have pretty bad dry or cracked skin, some erythema or desquamation, and this tends to happen within 2 to 4 weeks of treatment initiation, so it definitely happens quickly. I've included some lovely pictures here Again, you can kind of see that more kind of blistered, discraimed kind of picture showing up on those pressure points. For management, prevention, I do kind of reinforce that patients should get pedicures prior to treatment. That can be a tough sell for your male patients sometimes, but females tend to be pretty supportive of that recommendation. That kind of helps remove any areas that are calloused before they start treatment. They should be keeping their skin well moisturized, avoiding those vigorous exercises or repetitive activities that can stress the hands or feet. I often think of people who like to garden who end up pulling a lot of weeds. So if that is something that they like to do, they should know that that is going to be a huge risk factor for developing this, and they should use some cushioned gloves when doing that activity. Other recommendations, minimizing that exposure to hot water, checking out their footwear, making sure that's comfortable, wearing thick cotton gloves or socks at night, and then it's kind of repetitive, reducing that exposure to hot water. I've included some names of some creams that we'll often recommend to these patients. So Eucerin or Utterly Smooth. And then with this specific hand-foot skin reaction, urea creams or those with salicylic acid are really helpful in the management, which I've laid out here. So depending on the grading of these patients, we're potentially, going to be holding treatment if it's something really severe. And the earlier stages, considering things like the keratolytic creams like urea, applying cold packs for relief, or using some sort of low to moderate potency steroid cream to those kind of red erythematous areas. The other thing that we can consider for like a grade 2, if it's very painful, things like topical lidocaine gel, and then some oral NSAIDs or acetaminophen. So moving on to our last drug that we're going to talk about for renal cell. This is kind of an interesting drug that's on its own. It's belzutifan or Welireg. This is only indicated for treatment of von Hippel-Lindau disease. So you technically can use this for renal cell, CNS, hemangioblastomas, or pancreatic neuroendocrine tumors. But what this is, it's a small molecule inhibitor of hypoxia-inducible factor 2 alpha. And these HIFs are essentially transcription factors that regulate the expression of many genes downstream, like VEGF. So the inactivation of the VHL gene results in this abnormal stabilization and essentially accumulation of HIF2 alpha, which drives tumor growth. Side effects, because it does affect that HIF, anemia is by far the most common side effect we're going to be monitoring closely. This happens in 76 to 90% of all patients. Unfortunately, it can be severe, grade 3, and up to 29% of patients as well. Hypoxia is also possible if we have patients who, suddenly have more shortness of breath, difficulty breathing. Again, more commonly, we're kind of seeing that anemia first. But beyond that, I feel like this is a generally pretty well-tolerated agent. You, of course, can see some other like changes, arthralgias, fatigue that can happen with it. Things to note about that anemia, the median time to onset is 31 days, but it does have a pretty wide range of appearance, so it can be anywhere from a day to 8.4 months in the clinical trial. If they ever have a hemoglobin less than 9, this is within the package insert, or if they do have to have a transfusion, we need to hold treatment until they climb above 9 and then resume at a reduced dose or permanently discontinue if it's fairly severe. Included a nice picture on how this medication works, just kind of for your reference here. But, under normal kind of oxygen levels, HIF1 is hydroxylated, and that interacts with the VHL, which results in degradation by the proteasome. However, if you do have that change with von Hippel-Lindau, where it's inactivated, then we essentially have that kind of abnormal accumulation in hypoxia conditions, which leads to angiogenesis and then kind of cancer proliferation. The other thing I did want to point out, so the HIF1 target genes, it does target epoetin or EPO, and that's why we can see a lot of that anemia. So it makes sense why we have that kind of significant side effect. The last disease we're going to talk about today, I know it's been a lot of information, is lung cancer. So this has kind of exploded recently, our treatment of non-small cell lung cancer. we have a lot of these kind of targeting driver mutations that we can use. It's critical to assess for these mutations within the metastatic setting, as generally trials have found lower response to immunotherapy in patients who do have mutations. So we'll kind of touch on a few of the drugs within each category. I've kind of adapted this from our NCCN guidelines. As you can see, we have a lot of different potential mutations to target and a lot of drugs that are starting to come out for this use. One thing I do want to point out here, all of the medications that you see listed are technically kind of a first line, potentially subsequent, based on which specific mutation we're looking at. The standout here is that KRAS G12C agent, the sotorasib. It's only indicated at this point for subsequent treatment. And to continue that on the next slide, again, a lot more mutations that we've looked at for non-small cell lung cancer and now have agents that can kind of target those mutations. MET exon 14 skipping has also kind of involved in this MET exon 14 amplification. Technically, that MET exon 14 amplification is not an FDA indication for these agents yet, but it is listed as an emerging biomarker within the NCCN guidelines. So I'm thinking that eventually we're going to have that indication for those drugs as well, but certainly something that we can consider using for these patients. And I've bolded all the ones that we're going to highlight today. I think we'd need another extra hour if I talked about each drug individually for this class of medications. So we'll start out with our EGFR inhibitors. EGFR mutations occur in about 15% of all non-small cell lung cancer, most often within adenocarcinoma. This can happen in up to 35% within the Asian population. This tends to be more never smokers. And most often these mutations, about 90% of them are going to be exon 19 or exon 21. So certainly those are the most common ones that we have. Compared to our monoclonal EGFRs, these all kind of bind within that intracellular domain, kind of more downstream. But you can see that signaling effect downstream where you obviously blocking more at the EGFR receptor inhibits that activity downstream. The two drugs that we're going to talk about today, erlotinib and osimertinib. They're both once-a-day medications. Big difference is that erlotinib must be taken on an empty stomach, so 1 hour before or 2 hours after food. Differences in how they work, osimertinib does irreversibly inhibit EGFR, and that's why we can see some side effects like the cardiomyopathy and QTc prolongation with that agent instead of with the erlotinib. Drug interactions, for erlotinib, there tends to be a little bit more. We have CYP3A4. We also have to consider CYP1A2 inducers, which if you do have somebody who's still smoking while they have lung cancer, there's actually kind of interestingly a very specific dose titration of how we can increase that dose of erlotinib over time. Erlotinib is also very sensitive to acid suppressants, so we need to counsel patients to avoid H2 receptor antagonists, PPIs, and antacids. Kind of big takeaways for these two drugs, erlotinib, much more difficult to tolerate. It's not used commonly unless for some reason we can't get financial approval for osimertinib or the patient can't afford osimertinib. There's a lot more rash and diarrhea with erlotinib. Patients can also see a lot of nail changes, and weirdly, their eyelashes can actually get longer and thicker. If a patient has brain mets, erlotinib is going to be less effective as well. So when they're kind of looking at trials of these medications, they found more CNS progression with erlotinib. In summary, osimertinib is our drug of choice. It has good CNS penetration. It has activity against a specific mutation that can cause resistance. And it has, like I said, better CNS penetration all over. So our next class is the ALK inhibitors. This EML4 and ALK gene are within the short arm of chromosome 2. Inversion of these kind of results in this novel fusional oncogene, the EML4 ALK. This happens in about 2 to 7% of non-small cell lung cancer patients. And again, these tend to be younger and never smokers. So I've listed 3 of the more common medications here. The ones I would probably focus on and take away would be the alectinib and the lorlatinib. Alectinib is going to be our most often used first-line agent. It's dosed at 600 milligrams twice a day. It has to be taken with food. It's overall pretty well tolerated, but we can see things like myalgias, photosensitivity, and visual disturbances, potentially some edema as well. It does have good CNS penetration, making it a good agent for non-small cell lung cancer. Brigatinib is another option to use as a first line. It does have that dose titration initially, and that was kind of done because of the incidence of pneumonitis, which was higher when they started patients on 180 milligrams once a day. It has a lot more off-target effects. You can see kind of different side effects with brigatinib, like pancreatic enzyme elevation, CPK elevations, and then that cough or pneumonitis, important to look out for. Lorlatinib is usually a second-line agent, so kind of a third-generation agent. It's dosed at 100 milligrams once a day, non-specific with food. Big side effects, changes in cholesterol. So up to 81% of patients will have high cholesterol after starting. 60% will have just elevations within kind of triglycerides. The cognitive effects with this medication are real. So it can be anywhere from mood changes to hallucinations, changes in speech. More severely, it can cause seizures as well. This is the only ALK inhibitor or ROS inhibitor that causes these changes in cholesterol. So important to kind of have that as a big takeaway with that medication. For your reference, I have a table here on how we kind of manage it. Again, this can happen quick. Meeting within 3 weeks of the first lorlatinib dose, we can see those changes in cholesterol. A lot of patients end up having to go on a statin, and our drug of choice is going to be rosuvastatin because it will avoid drug interactions with the lorlatinib. If it continues to be an issue, if they still aren't kind of within our goal, then we need to add another agent like fenofibrate, potentially fish oil if it's the triglycerides. We also can consider something like Zetia or ezetimibe. Moving on to our KRAS inhibitors. So these are the most common oncogenic driver in non-small cell lung cancer. It's about 20 to 25% of all cases. It's usually an adenocarcinoma and more common among smokers, about 90% of the time. Again, you can kind of see that change leads to activation and downstream signaling. And so by blocking that with our inhibitors, we can kind of decrease that tumor cell proliferation. The current drug that we have is sotorasib. Dosing is 960 milligrams once a day, which does equate to 8 tablets. So it does have a little bit of a pill burden associated with it. A lot of drug interactions. It's a CYP3A4 substrate, and it also induces CYP3A4 as well. So it might affect other medications the patient is on. You do have to avoid acid suppressants with this medication. So whether that's PPIs or antacids, we need to counsel patients to avoid those. And the strange thing to kind of note with this one, the first dose reduction is down to 480 milligrams, which looks a little bit crazy. It is a 50% dose reduction, but that is what is recommended by the package insert. It's pretty well tolerated. What I've seen from patients is myalgias or arthralgias or fatigue tend to be a little bit more limiting and causing those dose reductions. The next class is our MET inhibitors. So as I said, we either have kind of that skipping mutation or potentially that amplification that can happen. That exon 14 mutation is found as about 3% of non-small cell lung cancer patients. However, what they found is that it can be an acquired EGFR TKI resistance pathway in about 20% of non-small cell lung cancer. So something that could be targeted later. Crizotinib's more of a historical agent now. It's not well tolerated. It causes a lot of visual disturbances and neuropathy. It doesn't have a lot of CNS penetration as well. So the newer agents like capmatinib and tepotinib have kind of taken over. These are more selective inhibitors of MET. Big side effects, edema can kind of happen anywhere, fatigue and arthralgias. We also can see some change in renal function. I think this is something where we might see MET inhibitors either in combination with EGFR at some point or potentially kind of used when we have resistance to EGFR TKIs. So this could be a part of non-small cell lung cancer that continues to progress. The next class is our RET inhibitors. So this is going to be in about 1 to 2% of all lung cancer patients. We can find these rearrangements. And again, kind of using that target to shut down that upstream pathway. Two different drugs that we have, so selpercatinib and pralsetinib. Takeaways on these, it can be kind of specific depending on which one you use, but if you can have food or not. We have more drug interactions with selpercatinib. It also has this chance of hypersensitivity reaction, which I'll show you on the next slide. But as you can see, a lot of side effects with these drugs, potentially not very well tolerated, and they do have pretty good CNS penetration. So just some pictures of what that hypersensitivity reaction could look like. It tends to be like a diffuse skin rash. They also can have fevers, potentially some diarrhea as well. So what we end up doing is treating with prednisone and continuing. And then our last set of agents are the NTRK inhibitors. So again, kind of something where we target specifically that change. Larotrectinib and entrectinib are the two drugs that we have. Differences between these two: larotrectinib is available as an oral solution, whereas entrectinib is only in capsule formulation. Cognitive dysfunction, again, is something that's big with these agents. The risk of bone fracture is pretty real as well, and you see a much higher increase, especially with entrectinib in our pediatric population. If we do use a solution for larotrectinib, it has to be kept in the fridge, and it can be hard to find, so we may have to dig around to different specialty pharmacies. Both of these drugs, we do need to make sure that we're watching liver function tests pretty closely. So this is just kind of a nice picture of all the different mutations that we can have, different pathways for signaling. I know we are close on time, so I'm happy to take any questions if there's any in the chat. Otherwise, I've included my email if you guys ever have any questions about lung or GU. I'm happy to help you guys. And thanks for your attention today.
All right.